Hi, good day. Welcome to the next section of our Fundo Friday presentations that's been covering the management of hypertension. So for this one, we're going to be going over severe hypertensions. So when the BP is really high, hypertension. So let's start off with the patient case because it's always good to have a subjective aspect for us to hold on to. And I'm sure we've all encountered something like this. So we've got a 54-year-old man. He's coming in for an ingrown toenail removal. He's not known with hypertension, and his blood pressure is 186 over 116, and this was appropriately taken. His pulse is 90, his SATs is 99%, DIP6 is normal, and his blood sugar is 6.3. So what do we ask? What are we going to do next? So importantly, it's always good to think about other symptoms that the patient might be experiencing. So the patient is actually asymptomatic. There's no other concerning findings or any problems on investigations, but that blood pressure is worrying us. So first, you need to classify the blood pressure that's happening here. And you're sitting with a systolic of greater than 180 and a diastolic of greater than 110. So this patient has got severe hypertension. But what does that mean? Well, he's got severe hypertension and it's asymptomatic. So this patient has asymptomatic severe hypertension. So what do we do next? So this is why it's useful to classify treatment, because then we can get advice on specifically the concern that we have. So here, the recommendations are to observe the patient in a healthcare setting and repeat the blood pressure after 1 hour of rest. Again, here it's important to do the blood pressure appropriately in a quiet place with the patient lying down, the blood pressure cuff at the level of the heart, or sitting with the back supported. We want to make sure we're using appropriate cuff. We want to make sure that the patient's bladder is empty. We want to make sure that we're looking after every aspect of this blood pressure management. If the patient's blood pressure is still at the same level, then we are going to immediately skip to oral treatment with 2 agents, hydrochlorothiazide as well as another treatment, and this is usually going to be amlodipine. Remember, we're going into step 3 of the standard treatment guideline, steps of antihypertensive treatment. We then follow up in 1 week and titrate accordingly. If the blood pressure is more than 160 over 100 after actual 1 month review visit, after the initial visit, then we need to refer this patient to a doctor. Now, the same patient comes back and now he's got a severe headache and he's got shortness of breath. The blood pressure is 190 over 120. Now what? This is now a hypertensive urgency. We asked about symptoms. We've got the shortness of breath and the headache. The blood pressure is 180 and greater, and the diastolic is 110 or greater, and there are symptoms. So the symptoms that are normally associated with hypertensive urgency, the severe headache, shortness of breath, and edema, pulmonary edema. The caveat, the bottom line to this is that, but these are not life-threatening neuro or cardiac symptoms that can occur at the hypertensive emergency, which we'll cover a bit later. So now what do we do? This patient's got symptoms. So we need to monitor this patient, ideally as an inpatient in a hospital setting. We need to lower the blood pressure with oral agents. So here we can use amlodipine and hydrochlorothiazide or furosemide. We're not going to give 2 diuretics at the same time, and we definitely want to use furosemide if the patient has pulmonary edema. And here the plan is to aim to lower the diastolic blood pressure. So the diastolic is our target here. And you want to have this to 100 or lower over the period of 48 to 72 hours. Remember, dropping the blood pressure too quickly can actually cause dangerous symptoms to occur. And we want to continue our patient on dual therapy or change the chronic treatment as per the guidelines. Now, this patient is having a lot of problems. He's rushed in with severe chest pain, shortness of breath, and pulmonary edema. This blood pressure is now 200 over 125. Now what? This is a hypertensive emergency. This patient has got serious symptoms Their blood pressure is 180 or greater, and their diastolic is 110 or greater. So for hypertensive emergency, the symptoms and signs that one finds, we need to examine the patient from the head down. Simplified. So the head, we need to look for blurred vision, and we can do fundoscopy and look for papillar edema. We need to think about mental status changes that can occur, and the patient may have lethargy, they may just be quite flat. We need to think about, has the patient had any seizures, and could they have experienced a stroke? For the chest, we need to ask about chest pain, shortness of breath, think about heart failure as an acute decompensation with pulmonary edema, and the patient may well have had a myocardial infarction. With abdominal aspects, we need to think about nausea and vomiting, as well as a reduced urine output, which you may only find by monitoring the patient ourselves. The potential causes for a hypertensive emergency could be something as simple as a patient having missed their medication. They may have had a stroke, they may have had a heart attack, they may have heart failure, and they may have kidney failure. The initial emergency management, and I just want to say again, the initial emergency management, which would be to give the patient 10 milligrams of amlodipine orally stat, and then to give furosemide 40 milligrams IV stat if there's pulmonary edema. Then this patient needs to be referred if you are at a primary healthcare clinic or a community healthcare center, or if they're in a hospital, you need to prepare a safe area to manage and monitor this patient in the hospital. So in casualty, you'd want them in the resus area, but ideally you'd want to get them admitted. And if you're going to be using your IV agents, you'd want them to be in an ICU or a high care setting. The next phase of this treatment would be controlled reduction in blood pressure. You want to be using IV treatment with short half-life drugs being your ideal medication of choice. So in a high care setting, you'd be using labetalol IV, 2 milligrams per minute, to a total dose of 1 to 2 milligrams per kilogram of our patient. If the patient has had an MI and congestive cardiac failure, then the recommendation is to use glycerol trinitrate, 5 to 10 micrograms per minute. And you also want to give them furosemide IV, 40 to 80 milligrams. This not only helps with the pulmonary edema, but also potentiates, so it makes the above medications work better. The oral therapy that you want to be giving here as well would be enalapril as a 2.5 milligram stat dose. This is your test dose. And then gradually increases up to 20 milligrams daily. And this is being titrated to the effect, so to your blood pressure, as well as to your renal function, which is why it's useful to have access to rapid turnaround blood services, blood test services. Specifically, the management of hypertensive emergency, this needs a bigger section. However, the most important concept here is that we need to aim to reduce the blood pressure without IV drugs, but not more than 25% of the mean arterial pressure within 30 minutes to 2 hours, and then over the next 2 to 6 hours can aim for a blood pressure of less than 160 of 100. And again, this must all be done slowly in a high care or ICU setting. Now, our patient has been successfully treated. They had a smooth hospital stay following the guidelines, and the patient is motivated to control his blood pressure and his lifestyle. He continues following up with you. He's got perfect adherence. The patient is a star at lifestyle intervention, and he becomes a health promoter, in fact. He lowers his blood pressure smoothly and safely. In conclusion, there's a high prevalence of undiagnosed, untreated, and uncontrolled hypertension. Preventing target organ damage and hypertensive-mediated organ damage is vital. There are good guidelines to follow for initial as well as ongoing management, and there are good guidelines locally as well as well-described international guidelines that we could also consider for the narrative of hypertension management. Lifestyle interventions are the foundation of hypertensive treatment and are also useful for establishing good communication between practitioner and patient, as well as relation building. We are empowered to manage this condition and in turn to empower our patients to manage their lives. Thank you very much and all the best wherever you may be practicing. Thank you.